Dr. Gardner, Peter Lockhart, great to meet you. I've been looking forward to working with you ever since I started. In fact, I looked up your article on pain assessment, and I've been looking forward to discussing it with you.
Okay.
I just saw Mrs. Buxton, and I have to tell you that I'm quite surprised with the way she's been managed to date. I don't think any of the residents are reading your article.
Okay, well, let me tell you how I'd like presentations to be made. I'd like you to focus on the pertinent findings, starting first with the chief complaint, the past medical history, social history, getting on to the physical exam and the pertinent positives in the labs and the x-rays. And then I'd like you to summarize with an assessment and plan.
Well, of course. I mean, this is my final rotation, so I'm very experienced with presentations. And I intend to go into pulmonary critical care, where efficiency is of the essence. I've learned to keep my presentations to under 3 minutes. The patient's a 76-year-old female with a history of osteoarthritis and chronic low back pain who states that she had a sudden exacerbation 2 weeks ago that's progressing and becoming more severe. It's centered on the low bilateral lumbar area with no radiculopathy or pain on palpation. However, when she sits up, stands up, or changes position, the pain is very severe. She denies any radiation of pain down her leg. She denies any weakness. She's had more difficulty walking due to pain and is now using a cane. Now, the patient states that her pain became so severe 2 nights ago that she came into the ER, and believe it or not, all they did was give her a dose of morphine and a prescription for Vicodin, which of course she couldn't get filled at, that late at night. I really don't think they knew what they were doing. I mean, there's no imaging mentioned or anything. She's had intermittent back pain for 2 years. She went on to a pain clinic for 9 months ago, and all they did was give her an epidural, which didn't work, and they sent her for acupuncture, which also didn't work. I don't know why she hasn't been sent to physical therapy at some point. Recent clinical practice guidelines indicate that all patients with back pain should get physical therapy. I have a copy of those guidelines right here if you want to review those.
We'll get to those later. Why don't you go on with your presentation?
Okay, as I was saying, past medical history is significant for hypertension, osteoarthritis, low back pain with a history of lumbar disc disease, osteoporosis, peptic ulcer disease, hyperlipidemia. She's had a hysterectomy at age 40. Medications include Plendil 10 milligrams QD, gemfibrozol 600 BID. She's recently been started on Bactrim DS BID for a UTI, and she's been taking Vicodin for the last 3 days. I don't know why they didn't start her on something for her bowels along with it. Everybody knows Vicodin causes profound constipation. She's allergic to Ephrin and Lipitor. Her family history is positive for cancers, but no other significant histories known. The patient's retired. She's independent of all other activities for daily living. She was previously ambulatory and cared for herself. She has no recent smoking or alcohol use. Review of systems indicates no headaches, no dizziness, positive for decreased appetite, positive for nausea, no shortness of breath, no cough, no chest pain, no palpitations, no nausea, vomiting. She's positive for constipation, no BM for 3 days, no diarrhea, no dysuria or frequency. She's had no numbness, no weakness in her extremities, no history of mood disorder, depression. Vital signs, blood pressure is 120/68, pulse of 72, respiration is 20, temperature 98.4. I mean, in general, the patient's alert, oriented, no acute distress. She's appropriate. And
Okay, let's stop there a minute. Well, very thorough. As I said, very thorough. But I stopped you because I want to give you some feedback about your presentation itself. You made a couple of disparaging remarks about the physicians who treated this patient and your perception of the quality of her care.
Okay, but I'm sure you agree that she was botched on several occasions.
I'm not going to comment on whether or not she was botched. That's unprofessional, and you need to be careful about judging your colleagues' care and accusing them of making mistakes. You and I were not there, and we don't know all the facts. We can talk more about this later, but for now, let's not let opinions bias your presentation, okay?
Okay.
And slow down and breathe. We've got plenty of time.
But if I'm supposed to do it under 3 minutes, it's...
You can do that by being concise, by not speaking so fast that no one can follow what you're saying. You were doing a good job. Just let me hear it, okay? So let's pick up with the physical exam and continue.
Okay. Eyes, conjunctiva, clear. Sclera anecteric, oropharynx is moist, no lesions, no exudates, neck was soft and supple, no mass is palpable, breathing was unlabored, lungs clear to auscultation bilaterally. Cardiovascular, regular rate and rhythm, normal S1 and S2, no JVD, abdomen was soft with positive vowel sounds and no masses, extremities show trace ankle edema. She has osteoarthritic changes in her hands, but good range of motion. She has 5 out of 5 motor strength, upper and lower extremities, equal bilaterally. Her straight leg raise was negative bilaterally. She's able to flex her knee up to her chest, both legs equal bilaterally. She also has good upper extremities extension with full range of motion. She has normal sensation equal bilaterally in the upper and lower extremities. On spine exam, she has no lumbar or lateral lumbar spinal pain upon palpation. However, with change in position with the range of motion of her spine, she has pain with flexion and extension minimally, no radiation. She had an MRI of the L spine 6 months ago, which showed mild disc bulging, L3, L4, and DJD. Plain x-rays today reveal no evidence of any compression fractures. Okay, so my assessment is I think the patient may have spinal stenosis. 6 months ago, she had a mild disc bulging and it may have progressed. This could lead to paraplegia if not acted on, and it can be cured with a surgical approach. We may want to have orthopedics or neurosurgery take a look at it for their opinion after we get an MRI and confirm the diagnosis. I also think that we should start morphine to control her pain. There's no reason for her to be uncomfortable while we wait for the others to act. We should also have physical therapy begin as soon as possible with her rehabilitation. Would you like me to make copies of these guidelines and papers for the charts and other members of the team?
Well, I'd like to review them first, and tomorrow we can discuss more of the details, but I'm glad to see that you're reading. And I'm really glad to see that you're able to take feedback and apply it appropriately. Good adjustments. Just keep your presentation to the facts and try not to jump to conclusions. Otherwise, you were very organized and thorough, and you did a very nice job. We can discuss your differential diagnosis and treatment plan in more detail after we see the patient, okay?